Ventricular septal defect, VSD. This is the commonest congenital acyanotic heart disease. And you see, this is right ventricle, this is left ventricle, this is endocardial cushion, this is membranous part of the septum, and this is muscular part of the septum. You see, this membranous part is downward extension of endocardial cushion, and this muscular part is upward extension of muscles of heart, apex, especially apex of heart. And according to anatomy, we have classified this ventricular septal defect in 4 types. Membranous type is 80%. This is membranous part of the septum, and defect in this membranous septum is called membranous defect. And membranous defect is near tricuspid valve. So septal deflect of tricuspid valve can get sucked in the defect, and it can lead to tricuspid regurgitation. And this is the commonest type of ventricular septal defect. Septal defect in membranous part of the ventricular septum. And defect in this muscular part may be multiple, and this septum looks like Swiss cheese if defect is multiple. Next is outlet or subpulmonic ventricular septal defect. This is subpulmonic ventricular septal defect. This defect is in between aortic valve and pulmonary valve. So part of aortic valve can get sucked in this uh, suprapulmonary VSD and can produce aortic regurgitation. This is only 5 to 7%. This is seen in 5 to 7% of the patients. And inlet type or atrioventricular is uncommon. This is inlet type ventricular septal defect, and this can lead to this is communication between ventricle and right atrium, and this can lead to AV nodal abnormalities and fascicular block, and this is uncommon, almost rare. Let us see hemodynamics of ventricular septal defect. See, this is the septum of the ventricle, and you see this is a defect. This is a defect in the septum of the ventricle. As we know, during peak systole, left ventricular pressure is 110 to 130 mmHg, and peak systolic pressure in right ventricle is 25 mmHg. So it's far below left ventricle. So blood from left ventricle will move to right ventricle throughout systole, and it will give rise to a pan-systolic murmur. And from this right ventricle, blood will go to pulmonary artery, and from pulmonary artery it will go to lungs, and from lungs it will oxygenated blood will come to left atrium, and from left atrium it will come to left ventricle, and from left ventricle you can see blood can either go to uh, aorta, or it can go to right ventricle. And right ventricle is also receiving from superior vena cava and inferior vena cava. So right ventricle is receiving lots of blood, even twice or thrice more than what is uh, systemic circulation. If systemic circulation is 5 liters, then this right ventricle can receive 10 liters or 15 liters of blood per minute, and so it can lead to pulmonary plethora, and later on it can there will be pulmonary hypertension. So what will happen, it will depend upon the size of defect. If defect is a small a small defect will produce pansystolic murmur, and it will be very harsh. And a small defect will not change it will not change the left ventricular size or right ventricular size, and there will be no pulmonary plethora, because less blood is coming to right ventricle. And but when this defect is bigger, large unrestricted variety, lots of blood, even twice or thrice uh, blood will come to this right ventricle, there will be hypertrophy and there will be pulmonary plethora. And in large defect there will be no murmur, because pressure difference is less, so there will be no murmur. And this uh, pulmonary part of second heart sound will be louder P2. And later after some time, time will come when this right ventricular pressure will be equal, or it can exceed pressure on left side. And when this pressure exceeds left ventricular pressure, what will happen? Blood will not come from left ventricle to right ventricle. Instead, deoxygenated blood will move from right ventricle to left ventricle, and this will give rise to cyanosis. This is called Eisenmenger syndrome. Clinical features: a small restricted VSD. A small restricted VSD is usually asymptomatic, incidentally detected. Whenever for some reason you are auscultating heart, you will get a systolic murmur, harsh systolic murmur, left parasternally in third space. Loud pansystolic murmur with thrill in third intercostal space, left parasternally. A smaller the VSD, louder the murmur, and larger the VSD, uh, uh, it will be less harsher murmur, and or it will at all disappear. Late in life, patient may develop endocarditis, even a small variety. Restricted VSD can develop endocarditis, CHF, pulmonary hypertension, left ventricular hypertrophy, but there will not be right ventricular hypertrophy. One of my colleague, he is about 40 years old, and he has clubbing in all 10 fingers, grade 4 clubbing. But he's working in a hospital, and he's doing his all normal activities, and he said his VSD is inoperable. He might be having pulmonary hypertension, but he is about 40 years old, so he must be having very small or restricted VSD. And now with age, he has now developed endocarditis, but in pulmonary hypertension. He has twice brain abscess. He suffered brain abscess twice and treated, and now he is all right. Till now, he is all right. Large non-restricted VSG. There, as we have discussed, there will be no murmur because pressure difference between two ventricles is very small. So there will be no murmur, but P2 will be loud and split because right ventricle is pumping till late. And diastolic murmur at mitral area due to large flow across mitral wall. There will be diastolic murmur. Recurrent chest infection, the infant will have with large and non-restricted VSD will have recurrent chest infections, and due to very large flow, infant will develop pulmonary hypertension, can have CCF, cyanosis, clubbing, and will have biventricular enlargement, and as later on Eisenmenger syndrome. Once Eisenmenger syndrome develops, patient becomes inoperable. You should not operate the patient. And with large or non-restricted BSD, with large BSD, even infant of 6 months age will develop pulmonary hypertension. So at 6 months age, we should try to correct it. Open heart surgery with patch graft should be done in early life. Investigations, X-ray chest with a small defect, there will be no change, and with large defect, there will be cardiomegaly, and cardiomegaly will be due to biventricular enlargement and left atrial enlargement. Lung field will be plethoric, and there will be pulmonary artery enlargement. In ECG, there will be features of biventricular enlargement and notched P wave because left atria is big, so there will be notched P wave. And with echocardiography, site and size of the defect can be diagnosed easily. Complications, failure to thrive, and repeated chest infections. This is very common in infants who has medium size or large VSD, repeated chest infection. Patient can have infective endocarditis, as I have told my friend who is about 40, he has infective endocarditis. And heart failure, even 6 months old baby can have heart failure. If there is heart failure and heart failure will happen due to big defect, and so at this age uh, we should operate these patients. We should correct heart failure and we should operate these patients, because later on patient will develop pulmonary hypertension and Eisenmenger syndrome in very early age. So before baby gets pulmonary hypertension and Eisenmenger syndrome, we should operate these patients. And in membranous variety, as already I have discussed, it's very close to tricuspid valve, and this defect will pull septal leaflets of tricuspid valve, and tricuspid valve can regurgitate, and aortic regurgitation. This is seen in outlet VSD or subpulmonic VSD. Mechanism is almost the same, and this tricuspid regurgitation uh, and aortic patient with tricuspid regurgitation and aortic regurgitation, they should be uh, operated. Open heart surgery should be done in these patients, and patient can have pulmonary stenosis. Treatment: a small or restricted VSD. The spontaneous closure is 80% in membranous or muscular VSD. A spontaneous closure is more common in muscular variety, and membranous type will also close spontaneously in small or restricted VSD. So just wait and watch. Do repeated echocardiography. Large or non-restricted VSD, medical treatment: treat heart failure, recurrent chest infection, and infective endocarditis if it's there. And for large and non-restricted VSD, open heart surgery should be done, and uh, defect should be closed with a patch. And muscular VSD is less common, just 10 to 15% of the patient, but treatment is easier. Muscular VSD can be closed with percutaneous occluder. Treatment is easier, but it's less common. Muscular variety is less common. Inlet and outlet VSD with TINI, as I have discussed earlier, it should be treated with surgically. It should be treated surgically. Open heart surgery with bypass. And contraindication, we should know contraindications also. Surgery should not be done in a patient who has developed pulmonary hypertension and Eisenmenger syndrome. Surgery we should manage conservatively with pulmonary vasodilators. And prognosis after surgery is very good for VSD patients. They live normal life. Thank you very much.